Welcome to the Medical Manners Podcast, where I give healthcare providers simple tips for ways they can transform the way they connect with their patients and colleagues. Connecting with patients isn't some secret sauce that some of us have and others don't. They're just skills, implemented consistently over time. If you want to transform your medical practice, you're in the right place. I am Katie Wyatt, your host. This episode is sponsored by the Connect Better audio course. This course is for healthcare providers who want to drastically improve their patient satisfaction or Press Ganey scores. Each week for 6 weeks, you will listen to a 5 to 10 minute audio training. Then throughout the week, your job is to implement the skills you're taught in every patient encounter. You'll be amazed at how much your score can improve in such a short amount of time. Go to medicalmanners.com and use the code PODCAST for 10% off the course. I have Dr. Pilcher, Charles Pilcher, here on the podcast with us today. Dr. Pilcher is a retired emergency physician and emergency department medical director. He currently serves on the Evergreen Health Governing Board in Kirkland, Washington, and chairs its Board of Quality and Safety Committee. He served as a medical legal consultant in malpractice cases throughout his career and is the editor and publisher of a free opt-in monthly newsletter, Medical Malpractice Insights, Learning from Lawsuits. So, Chuck, thank you so much for being on the podcast today. I'm excited to talk to you.
I'm honored to be here.
So the reason that you and I decided to do this call today is we both have, I would say, somewhat of the same passion. We're trying to help healthcare providers succeed in what they're doing. And I have loved your monthly newsletter. Let's get started with that. Maybe tell us how you got into doing medical malpractice and doing your newsletter.
Many years ago, I was contacted by our hospital attorney who works with our risk manager. And I was the medical director of the emergency department at the time. And she actually wanted me to review a case that she herself was working on, not on our own hospital, but on another hospital. She just wanted me to ask to render an opinion on what the chances of the case being valid would be. And so I said, sure, I'd be happy to do that. And I found it really interesting to read the medical records of another doctor, another emergency physician, and just see, is this the way I would do it? And she eventually referred me a couple other cases, and I found it very interesting, and especially working for the defense, keeping doctors from getting sued.
Yeah.
So that's how I got started. And then word just sort of spread. My name got on a listserv of attorneys, and they started calling me, and I found it just exceptionally educational.
Yeah.
I really didn't realize how much you could learn from the mistakes of others.
Well, I was going to say, this actually sounds like something we should all be doing. And maybe that's why we're encouraged to do our peer review type stuff that we do. Because even after reading your newsletter, I'm reading these newsletters that you send, and in my mind, I'm like, duh, right? It seems so obvious on paper, but it's taught me so much just learning from the mistakes of others and from these stories that you're telling.
You mentioned peer review, and that comes to mind as well as root cause analysis. I mean, we all do root cause analyses. Really, whatever happens to that information? How many times have you known? I mean, we have maybe one or two root cause analyses every month, and yet I don't ever hear, except through our quality committee, what did we learn from this and what did we teach others? And that's sort of the same thing that you and I are both trying to do, is learn from the things we aren't doing right.
Right. Well, that's awesome. And I will make sure that I put the link where healthcare providers can sign up for your newsletter. I'll put that in the show notes. I would recommend it to anyone. I don't work in the emergency department, but I've found it incredibly helpful for me as I'm looking at where things were missed. So it's a really valuable resource.
The fun thing about the malpractice work that I've done throughout my career was when I was working for the defense and was being deposed by the plaintiff attorney, and I wasn't giving him the answers that he wanted. And I apologized, and I said, I'm sorry, but this is the truth as I see it. And he said, well, Dr. Pilcher, I'm going to have to declare you a hostile witness.
Oh,
6 weeks later, he called me up and said, "Would you consider doing a plaintiff case for me?" That's one of the best honors I've ever had.
so obviously you weren't too hostile because he wanted to work with you again.
Right. And I've worked with him several times in the years since, and he's a great attorney. But what happened is that as I started moving into the plaintiff side, the defense people stopped calling me, and so the last part of my career here in this field, done mostly plaintiff. And most of the cases that I review for plaintiff attorneys are not viable cases, so that they, I tell my colleagues that what I'm doing by working for plaintiff attorneys is keeping them from getting sued. Really rewarding,
Yeah, that's awesome.
and not enough physicians actually participate in this process. But we need good docs, honest docs, to do this.
Yeah. Well, thank you for all you've done. I think it's great that you've done that, and I'm excited to keep learning from you. One of the best ways that, as I think about, keeping patients satisfied and happy with the healthcare that they're getting, time and time again, I come across studies that say one of the main reasons that we care about why our patients are satisfied, we do because it's the right thing to do, right? We should care about human beings. But beyond that, the more satisfied patients are with their care, the less likely they are to sue us.
Sure.
And that's been really well documented. And at the core of that is the better listeners that we are, the less likely we are to be sued. And so I wanted to pick your brain on this. You have so much experience in this field, and I would love to hear examples or your thoughts on how listening can make or break a situation.
Well, there's a couple of things that come to mind right off the top. Is that there's ample evidence that walking into the room where you're going to interview a patient, the importance of sitting down, for instance, just
Mm,
looking relaxed, being able to, standing up, you look like you're in a hurry,
yeah.
or giving the patient the time they need. So that's the first thing, sit down. And then we have what's called the history and physical, H and P. What's more important, the H or the P?
The H for sure.
You know, probably 50 years ago, people do studies on this sort of thing, and they found that 72% of the diagnoses that are made can be made from the history alone. And now actually, excuse me, that goes backwards. It was about 80% could be managed by the history alone. But now it's down to 72%, but that's only an 8% loss in 50 years. And that with all the technology we have, we now depend on not only 8% more than taking a history. So listening to the patient is crucial. And the other funny thing that we know, besides the importance of sitting down, is not interrupting. Statistics show that the average physician will walk into the room, even maybe sit down, ask a question, and within 18 seconds or less, they will have to interrupt the patient who's trying to give you the answer to the question you asked.
Isn't that crazy? Can you imagine if you had to say something important and you knew you only had 18 seconds
Yeah,
to say it?
yeah. I listened to your podcast from Dr. Is it Abramson or
Yeah.
Abrahamson?
Abramson. Yeah.
I was very impressed with him. I highly recommend that podcast to anybody that has access to it. But the takeaway for me from him was when he said, your job is not what is the matter. Your job is what matters. Take away the what matters to you. And that's exactly, if I, like you said, call up with a sore throat or something and want your advice, the question is, what's on my mind? You want to know, as the treating clinician, why am I calling you?
Yeah.
Sure, I have a sore throat. Lots of people have a sore throat. Maybe my problem is, can I go to work tomorrow? Is it strep? Do I need an antibiotic? Learning what matters to the patient is the crucial aspect of the interview. And I was very impressed with Dr. Abramson's approach.
Yeah. He is such an awesome guy. I'm impressed by him too. Well, and I love what you're saying here. So you're saying that if I walk in the room and I just sit down and I listen for longer than 18 seconds, I mean, those are extremely simple things. And those two things alone, I've put myself ahead of the game, right? Just by doing
Right.
those simple
Absolutely.
things. Have you ever heard of Dr. Bernard Lown?
LOWN.
Lown. Yeah.
He's the one that created the Loan Institute.
Yeah.
Yeah,
He created the defibrillator.
really.
And yeah, I mean, he's the one that
And he was a cardiologist.
yeah. He discovered, I mean, I don't know if it was only him, but he was on the team that discovered that lidocaine could be used to control abnormal rhythms of the heart. He created the first defibrillator. And I read his book last year, and it was so interesting. He said, pretty much to your point that the history is the most important part, listening is the most important part. He said, of all the tools in my repertory, listening is my most valuable tool. Coming from the man who discovered how to start someone's heart again, right? And listening. Listening is the most important tool he had. So we're going to go in, we're going to sit down, we're going to listen to our patients and try not to interrupt. Beyond that, what have you seen as far as malpractice cases that have gone through? And maybe you can give us some examples where listening didn't happen and there were poor outcomes.
The biggest problem, I'm an emergency physician, and we usually have only one shot at making a first impression.
Mm-hmm.
You don't get a second opportunity to make a first impression.
Yeah.
That's where the interruptions come in. If you start interrupting too soon, you aren't making a good impression.
Yeah.
But the importance of listening is critical. And the problem that leads to the most lawsuits probably is what's called anchoring bias. There's a whole lot of things called cognitive biases and different ways that we don't think the way we should. Anchoring bias is grabbing hold of the first thing that you think of when the patient starts telling their story. And you think, well, chest pain, oh, it's probably a heart attack. Or maybe it's rib pain, whatever. But what sticks in your mind is the first thing you think of, and you think, oh, this is going to be an easy case.
Yeah.
Don't allow your mind to go a little beyond that. That's what's called anchoring bias. There's also confirmation bias. For instance, you get a CBC, blood count, just to see if if an infection is there. And you look at the lab report, white blood count is normal, but you don't look at the differential.
Mm.
May have a white count of 6,000, 7,000, which is in the normal range, but it's 90% neutrophils and 10 or 20% bands. But if you don't look at the whole thing, you're looking for what you ordered the white blood count to see if it's normal. You see that it's normal, and that's where you stop. That's confirmation bias. You didn't look far enough.
One of the ones you mentioned to me was, I'm trying to remember which one it was, where we relied too much on what it's been in the past for the patient.
Availability bias, is that the one that might be, you just saw a case of this yesterday, so now this has got to be another one of the same things. That's availability bias.
Yeah, maybe that was the one. But I thought, man, how often do we look at the patient's chart, and before we've even seen the patient, we see what it was the last time, and then we see their chief complaint, and we've already made a diagnosis. Before the patients even had their 11 seconds to talk, we've made a diagnosis.
An example of that would be a recent case that I wrote up about a patient who was legitimately a drug user, but she had severe back pain and was very outspoken about how bad her back was hurting. When you have a patient like that with a drug using history, you're going to start being a little prejudiced, or you're going to start thinking this is just another person looking for drugs.
Right.
In this particular case, I mean, this patient was screaming in pain, 10 out of 10 pain, very dramatic. And the doctor in this case just closed their mind and stopped thinking about what other things could this be. I mean, and it turned out that it was a spinal epidural abscess. But the thing that wasn't considered in this case is the risk factors for spinal epidural abscess, one of which is being a drug abuser, especially IV drugs. Diabetes is another risk factor. Recent surgery is another risk factor. But if you don't start thinking out of the box and giving the patient an opportunity to tell their story and you asking the right questions to learn what's been going on, how long has this been going on? And like Dr. Abrams said, what matters to you in this? And usually the thing I found with drug seekers, I acknowledge that that's a prejudicial term, drug seekers, but we all use it. I mean, we know what it means.
Yeah.
It's just too easy to fall back on what we suspect and give the patient an opportunity to tell what's different about this than any other time you've had a similar back problem.
Yeah. I did a podcast episode where the term frequent flyer came up. And you know the term, right? We have our frequent flyers in the emergency department. And a physician's assistant reached out to me who, she knew the term frequent flyer. She'd used it forever, but she suddenly found herself in a situation where she was having chronic headaches and she ended up in the emergency department 2 months in a row. And the first time they were kind to her, and the second time they kind of just shut her down. They saw that she was in the month before, and she said, suddenly I had become a frequent flyer. And it was so interesting to hear her take on it from the patient side. I think it's just to your point that as much as we can, we need to be in the moment and think in the moment and try not to let that other stuff affect us as much.
Yeah, the biggest problem we have as physicians is that we don't know what we don't know. And if you allow yourself to not go on a little bit deeper and just think, what's the worst thing that could happen here? What could I be missing? If you start thinking about what this could be, start with the worst things. I mean, what if it could be a spinal epidural abscess? Just by asking questions and experience of talking to patients, you can tell when a patient is telling the truth or seriously worried. Frequent flyers or drug seekers with high risk factors for spinal epidural abscess will usually stand out as this is different. I mean, if you ask them, what's different about this? You've been in here 3 times in the last 3 months. Why is it different today? With any experience, you can usually tell whether the patient is flying frequently or telling the truth. Something's different. And that's what you're looking for. And that there's a whole science of what's called metacognition. In other words, starting to think about what you might not know. Think about your own thinking processes and use what should be going through your mind at that point to reframe the questions you're asking and eliminating the serious things that could be going on.
Yeah. I love that. I think it's going to change the way that I see patients. I hope that I pause and just say, what am I not thinking about right now? What could I be missing right now? And just taking that extra, I mean, it's probably only 5 seconds, but just taking that extra moment to think, could it be anything else?
And this is where Dr. Abramson's comment comes in about it's not what's the matter, but what matters. And you can then reframe your questions and listen to the patient for more than 18 seconds.
Right. Tell us, if you can, the story that you put out in your January newsletter about the ankle contusion to colectomy. I could not believe this story. It sounds unbelievable. And so I want to hear it from you.
Okay. There's a young man that his chief complaint was, my leg is red, blue, and swollen.
Mm-hmm.
What happened? Well, I banged my ankle against the chair. And the provider immediately looked at the ankle. It's blue, it's red, but mostly red. It's been about 3 or 4 days since this happened. The patient's concerned about what he should do about it. Maybe it's broken or whatever. The provider stopped thinking at that point, looked at the redness and said, oh, you've got cellulitis. You've got an infection in your ankle from this injury. He started the patient on an antibiotic. A few days later, he starts feeling nauseated, starts to vomit, has some diarrhea, goes to his primary care physician. The doctor says, well, the antibiotic is not working. Let's get a different one because you're having a side effect from it. Started him on another antibiotic. To make a long story short, he ended up in the emergency department, and finally the emergency physician found out that the antibiotic was causing him C. difficile gastroenteritis. He was already so badly injured from the C. difficile colitis that he had to have a colectomy. And if you look back at the original story, one of the things that happens with a bruised ankle is that the purple starts to go away. The iron in the red blood cells that are in the area of injury start to dissipate, and iron start to create an inflammatory. As the red blood cells break down, the bruising goes away, but the iron in the broken down red blood cells will cause an inflammatory reaction. That's not cellulitis. It's just reacting to free iron in your skin. And we see that a lot. I don't know how often people recognize it, but it does look a lot like cellulitis. So there was a delay in recognizing that antibiotics cause C. difficile colitis, but it was sad because metacognition didn't happen. What else could this be? Why, I'm thinking it's cellulitis, but do I really need an antibiotic? Could it be something else? And then making it worse by adding another antibiotic didn't help at all.
Yeah.
And it really ends up without a colon.
Well, and I think in your newsletter too, it said that because the patient had some unilateral leg edema, then they checked a BNP. Then they said like he's in heart failure. Anyways, it was like this crazy.
Yes.
It was like this crazy chain of events, and all the guy did was bump his ankle.
Yeah, and they thought congestive heart failure because his ankle was swollen. Only one ankle that caused congestive heart, half the side, half the body.
Yeah. And I mean, hindsight's 2020, right? So it's easy for us to look back and be like, oh my gosh, what is happening?
Yeah.
But like you said, I mean, taking that moment first to listen, like this patient hit their ankle on a chair, and listening to that story.
And the skin was even broken.
Yeah. And then when they do start having diarrhea from that first antibiotic, not being so stuck on the cellulitis that we can't take a minute and pause and think, he's on an antibiotic and he has diarrhea. Could this be C. diff? And catching that C. diff at the beginning instead of,
yes, these things happen, and it's human nature that we don't always like to question our own thinking processes. But it's, I find it just amazingly educational and almost fun sometimes to look at the ways in which we can make mistakes. But it all starts with taking a good history, listening, and realizing that you aren't always making the right decisions and need to think about your own thought processes.
Yeah. In your opinion, what's the most important thing that we can do to keep ourselves out of lawsuits?
Ask good questions, listen, and then think about the things that you might not be thinking of. In other words, ask yourself, am I on the right track? Could this be something other than what I first thought? And just be open to other options. You may not be right the first time.
Yeah.
Another thing that I'd just like to share with you, you wanted to ask me how I got started in doing this newsletter. It was the year 2014. I was starting to do plaintiff cases, and I got contacted by 4 different plaintiff attorneys, all in the state of Washington, all with patients who had injury from missed spinal epidural abscesses, all in the same year. And I'm thinking to myself, this is crazy. The thing that bothered me was that every one of those cases, nobody learned a thing from. Each of those attorneys had non-disclosure clauses, confidentiality clauses, basically gag orders. Nobody, once the case was settled, and these kind of cases settled, they don't go to trial because they're all winnable.
Mm-hmm.
And so nobody learns anything from this. And what bothered me the most is that all of the patients, I eventually had 12 spinal epidural abscess cases I'd worked on. It occurred to me that, well, let me back up. What their main concern was, as it is with most lawsuits, I don't want this to happen to somebody else.
Mm-hmm.
And none of those patients, I mean, I've had this vision of inviting all of those 12 people whose cases I reviewed. I wanted to invite them to dinner at a nice restaurant, have them all come in their wheelchairs, sit around the table and look at each other and say, I thought I was the only one that this ever happened to. Didn't learn anything from my experience. And it
Yeah.
was just one after another. It's just sad that we are not learning anything from our malpractice lawsuits. And it's not, we aren't trying to blame anybody. We're just trying to learn.
Yeah.
And I have, three purposes in doing my newsletter. One is to educate physicians. The other is to improve patient safety. And the third one is to keep us all out of court.
Yeah. Well, and like you said, we hope it never happens to one person. I mean, that would be ideal, that we don't make any mistakes ever. But if a mistake is made, then let's have that be the only time. Yeah. Why aren't we learning from this?
There's just so much learning opportunity in these cases. And
Yeah.
the way we think when we're dealing with patients, we don't want to make those mistakes.
Yeah. Well, I mean, for that reason, I am so grateful for what you're doing. And like I said, I don't work in the ER, but I will be a faithful reader of your newsletter every month because I'm learning things.
Thank you very much.
Thanks for listening. If you enjoyed today's episode, the best way to support what I do is by rating and reviewing the podcast. Your feedback helps me reach more listeners to make an even greater impact. It would also mean the world to me if you would share it with a friend or colleague who you think could benefit from the topics we discuss. Together, we can transform the way we deliver healthcare by transforming the way we connect. Take care.